Thank you, Dr. Sabala, for inviting me over again for the session on epilepsy and anticonvulsant therapy. I almost forgot about the session today. I kind of remembered 45 minutes ago I had to come rushing here. But I have done this talk several times, so it shouldn't be a problem. Okay, so here and the next few, let's see this. Getting used to the mouse is probably more. Is the mouse okay? Just click anywhere? Yes, left click. Yep, I'm doing it. Okay, thank you. So in the next 45 minutes, we are going to look at what exactly epilepsy is. It's a definition of epilepsy. And few common scenarios you would face in the boards as well as in clinical practice in terms of febrile seizures, first unprovoked seizures, and common epileptic syndromes which a general pediatrician is expected to recognize, and from broad strokes about treatment approaches. In terms of what is the definition for epilepsy, it's probably best defined with these three terms. Recurrent unprovoked seizure equates to epilepsy. Unfortunately, each term is loaded with further definitions, what exactly is recurrent, what is unprovoked, and what is seizures. Seizures is probably the easiest thing to say. Seizure is a set of symptoms, a paroxysmal set of signs and symptoms due to abnormal synchronous hyperactivity of the neurons. So it's easy to conceptualize our EKG and the cardiac rhythm abnormalities. You have a normal sinus rhythm, and during an arrhythmia, you have a sudden change in the rhythm. And since the heart does only one thing, you have the same set of symptoms in most of the cardiac arrhythmias. In neurology, again, you have a baseline normal EEG rhythm, and during the seizures, there is a hypersynchronous firing of the discharges of this baseline rhythm. Because the brain has different function, depending upon where these discharges are happening, you can have different kind of symptoms. If it happens in your motor cortex, it produces motor symptoms. It happens in your vision cortex or calcarine cortex, it will lead to visual symptoms. So basically, a paroxysmal hypersynchronous discharge from the neurons. So in terms of what is recurrent, the epidemiological definition for a recurrent is 2 or more seizures separated by 24 hours apart. This is because it has been found that patients who have, the patients who have either 1 seizure or 4 seizures, which happens within a 24-hour period, their long-term risk for future epilepsies or recurrent unprovoked seizures in future is essentially the same. That's why 2 or more seizures separated by 24 hours apart has been proposed. In terms of what is provoked, any seizure that is provoked exclusively by fever would be called as febrile seizure provoked seizures. And a concussion a seizure that follows soon after a concussion would be called a provoked seizure. A hypoglycemia or a drug withdrawal seizures or a convulsive syncope, all those things would be called as provoked seizures. So these won't be classified as epilepsy, even this happens over and over again. Sometimes we call it as situation-related seizures or provoked seizures. If you look at the International League Against Epilepsy definition, again they emphasize 2 or more unprovoked seizures separated by 2 or 24 hours apart. But recently we have revised the definition in terms of even you may be able to make a diagnosis of epilepsy even with 1 episode of seizures if the recurrence risk is expected to be more than 60%. For example, the recurrence risk is usually determined by abnormal neuroexam, abnormal neuroimaging findings, or abnormal EEG. All these things will elevate the risk of recurrence of seizures. So if those things are present in selected patients, especially in the adult population with 1 seizures, one may be able to diagnose epilepsy. And there is a separate category of diagnosis of epilepsy syndrome. Sometimes 1 seizure may be sufficient to make those diagnoses. And as you can see, all these definition principles are based on the risk of recurrence. So even if there is 1 seizure, if the risk of recurrence is high, you may diagnose it as epilepsy. This is because this study as well as later studies have confirmed that the recurrence risk after 1 seizure is about 1/3. That's what we say, everybody get 1 for free because 2/3 of them may never have another seizures. After second seizure, the recurrence risk is high, up to 73%. So that's when we practically make a diagnosis of epilepsy when there is 2 seizures or more. Again, when there is an abnormal exam finding or abnormal EEG or abnormal neuroimaging findings, all these things will elevate the risk for recurrence of seizures to more than 60%. That would qualify for definition of epilepsy. Now that we have gone through the definition, let's talk a few important aspects of febrile seizures. Febrile seizures, as you know, it's a common seizure. It's probably general pediatricians see more often than epileptologists, definitely. And it's about 2 to 5% of all children may have had one or more febrile seizures during their lifetime. The median age is around 18 months. It is 6 months to 6 years is the classical period, but majority of the children will have had their first seizures before 3 years of age. And 50% of febrile seizures, as you can mention here, 12 to 30 months of age. As all of you know, we call it as complex febrile seizures if any one of the following is present. Whether the seizures lasting more than 15 minutes, some literature say 10 minutes, or if there is any focal features during the seizures. So it is important to take the history, what kind of seizure the patient had, if there is a febrile seizure. If it is focal, it would qualify for complex febrile seizures. And if there is a recurrence within 24 hours, it would also qualify for a complex febrile seizure. And the importance is, this often tested in the boards, is they test on what is the recurrence risk for febrile seizures in future versus the recurrence risk for epilepsy in future in a child with provoked or unprovoked seizures. The recurrence risk for febrile seizures is about 30% will have a recurrence, which means the majority still may not have a recurrence after a single seizure. 50% will have recurrence if there is 2 or more seizures, definitely. And the common risk factors that has been identified are lower temperature at the time of seizures, age less than 18 months. It also gives a longer period before they outgrow the tendency for febrile seizures. Shorter duration of fever, that is the seizures sometimes even occur even before the family recognizes fever. And there is a family history of febrile seizures. All these things will increase the risk for future febrile seizures. In terms of risk for epilepsy is concerned, practically there is no increase, that's one thing. So when you see a child with a febrile seizure, it's important to tell them, this is not a diagnosis of epilepsy, this is a provoked seizure. This is a febrile seizure, not qualify for the diagnosis of epilepsy. And if you look at population studies about the general population risk is around 1.4%. In febrile seizure cohort, it's been determined to be 2.4%, a slight increase. The important factors that determine are the family history of epilepsy, neurological abnormality in the child increases the risk for, especially in the setting of a complex febrile seizures. So family history of epilepsy is probably the most important thing that predicts the future risk for epilepsy in patients even with complex febrile seizures. And as you know, febrile seizures does not affect cognition development. There is no history of any SUDEP reported. SUDEP stands for sudden unexplained death in epilepsy, which is a concern in children with refractory epilepsies. In terms of testing for febrile seizures, in almost majority of situations, you don't need any testing. You don't need any EEG, imaging, electrolytes, lumbar puncture. Sometimes there is a practice to do in children with complex febrile seizures. There is a tendency to do EEGs. I often do not know what we would learn from them or how it would change the management. But sometimes the seizures may be lowering the threshold for epilepsy. So if the EEG shows frequent abnormalities, focal abnormalities in a child with complex febrile seizures, that may indicate a first episode of seizures that is triggered by fever in a patient who's prone to have epilepsy in future. Lumbar puncture, as you know, is strongly recommended if there is signs of meningitis. It's a no-brainer there. And one should consider LP if the child is unimmunized, especially in an infant. And that's the first episode of febrile seizures, so-called febrile seizures. In a child who is pre-treated with antibiotics, one may consider. As you know, before 1990s, mid-90s, all children with the first febrile seizures, infants, all of them got lumbar puncture. You should have a real good reason not to do a lumbar puncture those days. But since the advent of immunization and the vaccination for the H flu, pneumococcal, the incidence of meningitis in this age group has dramatically declined. That's why nowadays, if you have a febrile seizure in an infant, you should have a real reason to do a lumbar puncture. It's the reverse. In terms of treatment for febrile seizure, there are only 2 things. One is counseling, reassurance for the families, number 1. That's more important. And the second is preventing prolonged seizures. Because about 50% of tonic-clonic febrile seizures, they last more than 4 minutes. And the population studies have shown that the longer seizures are not uncommon with febrile seizures. So I often, especially when the first seizure was longer or there are recurrent febrile convulsions, I often prescribe a rectal diazepam to prevent prolonged seizures. So they use it at the 3-minute mark or a 5-minute mark, depending upon the patient. Antipyretics as needed for fever, but there is no evidence that it actually reduces the seizures. A few words about febrile seizure genetics. As you know, there is a strong family history for febrile seizures in children who have had febrile seizures. And there is one epilepsy syndrome that is particularly associated with an increased risk for seizures and status epilepticus with fever. It's called the Dravet syndrome. Dravet syndrome is a sodium channelopathy, typically associated with sodium channel 1A mutation. There are other sodium channels also been linked to it. And these children typically present with prolonged focal motor status epilepticus triggered by fever in the infancy. It may start on left-sided, and the next time would be right-sided seizures. And subsequently, they start having unprovoked seizures, myoclonic seizures. It's also called a severe myoclonic epilepsy of infancy. So myoclonic epilepsy, febrile seizures, prolonged status in a child with a neurological developmental regression, one would diagnose Dravet syndrome. So this is a cartoon that illustrates the spectrum of febrile seizures and epilepsies. As you can see, the blue lines indicate febrile seizures, the dark lines, the black lines indicates unprovoked, and you have on the x-axis the age from months to years. The febrile seizure, that's a typical course, and most of them stop having it before 6 years of age. Febrile seizure plus, we would call when children have continued to have fever-triggered seizures without unprovoked seizures beyond their usual age group. And then epilepsy with febrile seizure plus, and these children may start off with febrile seizures, but subsequently they also have unprovoked seizures without fever. Then that's the time we call it as epilepsies with febrile seizure plus. And sometimes epilepsy, the seizures may be triggered by fever. So this is a patient who has had seizures with unprovoked seizures to begin with, subsequently has increased seizures during periods of febrile illnesses. And a very rare instance is sometimes you can have febrile status epilepticus in infancy, and they never have anything, and subsequently at a later age, they develop what we call mesial temporal lobe sclerosis. It leads to temporal lobe epilepsy, which is a relatively less frequent substrate these days with aggressive treatment of status epilepticus. Now moving on to the next section. So we started with definition, we're moving to febrile seizures, we covered febrile seizures, now moving on to first unprovoked seizure. Again, as I mentioned, with a single unprovoked seizure, one would not diagnose epilepsy unless there is a higher risk for future. For in practical purposes, in children, one seizures, we don't call it as epilepsy because most of the time we are not starting anti-epileptic medications. The recurrence risk after a first unprovoked seizure, depending upon population studies, the adult studies have shown 33%, 33 to 40%, the pediatric studies close to 50%, and the 10% may have more than 10 seizures in their future. And the risk factors, as I mentioned, abnormal neuroexam, abnormal EEG, abnormal MRI, all these things increases the risk for future seizures. Most children do not require treatment with a single first unprovoked seizure, but if the first seizure was longer, I would often prescribe a rectal diazepam so that they use it in case if there is a prolonged second seizure. But it doesn't mean that no testing is required. You often need some kind of a workup to find out what is the reason for the seizures. First seizure may be a manifestation of a malformation or an old stroke, or maybe a brain tumor. So depending upon the type of seizures and the EEG findings, one may have to do imaging also in many patients if the etiology is not clear from clinical history. And in young adults and teenagers, one would often consider toxicology screening as well. So let's look at this first question. So we have a 3-year-old girl who presents with a 15-minute long seizure, started as left face and arm jerking and later as generalized tonic-clonic seizures. She was sitting and eating her lunch at the time of seizure. Medical history is significant for brain hemorrhages due to non-accidental trauma in early infancy and subsequent global delay. She's now 3 years old. Of the following, the factor most predictive of seizure recurrence. In the boards, they often test for our understanding about the risk factors for seizure recurrence. Occurrence with fever. B, history of febrile seizure in 2 siblings, neurological impairment and delay, coexisting cardiac disease, placement in foster care. So we covered some of these things. I guess most of you got it right. The presence of neurological impairment, either neurological exam or developmental delay by historically, or neurological imaging findings and abnormal EEG, obviously all those things will increase the risk for future seizures. Moving on to the next section, common epilepsy syndromes. So this is a newer classification that was proposed last year by the International League Against Epilepsy. They have multiple levels of classification. Number one is the seizure types. As you know, you have, broadly speaking, we have focal seizures and generalized seizures. Focal seizures means the symptomatology suggests that the seizures are starting from one region of the brain or one side of the brain. Generalized means the seizures are in the seizure symptomatology suggests that both sides of the brain are simultaneously activated. And many times, going by the history alone, one may not be able to determine whether it is focal or generalized. And in terms of epilepsy type, this is for the seizure type, single individual seizure type. And then you have epilepsy type, where patients will be classified as focal epilepsy, generalized epilepsy, and it's not uncommon to have children with both generalized and focal features. Sometimes you do not know. And there are some specific unique epilepsy syndromes, which includes benign Rolandic epilepsy or a Dravet syndrome I talked about, that come under the next category. And we often try to emphasize on the comorbidities, which is common. Almost 40 to 60% of children with epilepsy, they have some other comorbidities. And these are the broad categories for the etiology, which includes structural abnormalities in the brain, genetic causes for epilepsy, infectious causes, especially in certain developing countries. Chronic epilepsy, one of the common causes in some parts of India where I trained was neurocystic sarcosis. So a child comes with seizures to the emergency room, we make a diagnosis of neurocystic sarcosis, it'll be 90% of the times he'll be right. So depending upon the location depending upon the part of the world one sees the patients, the etiology could be different. And metabolic etiologies, I mean, we have the new category of autoimmune disorders, which is being increasingly recognized as an etiology for epilepsy. So we will go over some of these epilepsy syndromes, which is commonly tested in the boards. And one is the self-limited childhood epilepsy, also called the benign focal epilepsy of childhood. And the two common categories we see in practice are benign Rolandic epilepsy, which is one of the commonest unprovoked seizure condition in pediatrics. Almost 20% of children with the new onset seizures unprovoked I see are related to benign Rolandic epilepsy. Panayotopoulos syndrome, which is also a benign focal epilepsy with specific seizure symptoms. And we have epileptic encephalopathy, which in the past we used to call it as catastrophic epileptic syndromes because they have abundant seizures, difficult to control, and their EEGs are very abnormal. The common ones are the West syndrome and Lennox-Gastaut syndrome is the other one. And we have generalized epilepsies, they typically occurring in the pediatric age group is the childhood absence epilepsy, and we'll go over some of the features of these specific conditions. One of our pediatric neurology professor, Dr. Rothner, likes this classification. It's a Clint Eastwood classification of epilepsies. It's called good, bad, and ugly. The good ones are the benign epilepsies, where children have good chances for remission in the long term. And the ugly ones are the catastrophic epilepsies, where you have the West syndrome, Lennox-Gastaut syndrome, Landau-Kleffner syndrome, and other categories. And many patients fall in between. Many of the lesional epilepsies, which are well controlled on medications, they may require long-term treatment that comes under these in the middle category. I usually use this classification only when I'm seeing children in the good category so that we can counsel them appropriately. So this is a cartoon that illustrates the different benign epilepsies that occurs in different age groups. As you can see, it's less than 1 month, less than 1 year, 4 to 6 years, this is the peak age, and 6 to 10 years. And these benign epilepsies, basically because they have fewer seizures, majority of them, They have good response to medication if they need treatment. Many of them, we don't use treatment. They often have normal neuro exam. They have good chances for long-term remission, and they have an idiopathic etiology. They do not have an abnormal neuroimaging findings that EEG and the seizure symptoms and the clinical profile would be diagnostic, which include benign neonatal seizures, benign myoclonic epilepsy of infancy, this Panetta-Polo syndrome, the peak age is between 4 to 6 years, and the benign Rolandic epilepsy. These two are the ones we are going to go over. And if you look at the features, as once again I am highlighting this, they are self-limited focal epilepsy of childhood. In the pediatric literature in the boards, the term that's often used is idiopathic partial epilepsy. Idiopathic generalized epilepsy and idiopathic partial epilepsy. So the self-limited focal epilepsy of childhood is the same as the idiopathic partial epilepsy. So you have a normal child otherwise developing normally. They have infrequent focal seizures, often in sleep. That is one of the typical features. In majority of the times you would see seizures in sleep. And their EEGs are usually very abnormal. That's why we have a saying in pediatric epilepsy, the child looks terrific and the EEG looks terrible. That may be a benign focal epilepsy of childhood because the EEG shows abundant epileptiform discharges. They have no other cognitive problem. Sometimes when the seizures are frequent in about 10% of children, they may have significant learning issues as well. And the learning issues may be worse during the periods of increased seizures. And once the seizures go away, usually most of them outgrow when they hit puberty. And the learning issues may also recover. The most common benign idiopathic self-limited childhood epilepsy is the benign Rolandic epilepsy. It's called Rolandic because the seizures are originating around the inferior part of the Rolandic fissure or the central sulcus. As you know, this is the frontal lobe, that's the parietal lobe here, you have the central sulcus, and you have the motor area of the face here, the sensory area of the face here. And if you carefully take the history, majority of patients may have a clonic jerking of the upper limb, often with the face. They may have abundant drooling from their mouth. There may be face twitching. And many children may be walking to their parents' bedroom having this twitching on the face and the arms, and they may be fully aware. If it happens on the left side of the brain, an older child, they may not be able to talk because if it affects if the language hemispheres, language regions are closely adjacent to this region. So hypersalivation, face twitching, arm twitching, less frequently leg twitching, but they can have a generalized tonic-clonic seizures. Sometimes the focal feature may be missed because the child was sleeping, had a focal seizure, and subsequently the family noticed only when the child had a generalized tonic-clonic seizures. So just because a child came with a grand mal seizures or generalized tonic-clonic seizures in sleep doesn't mean that it is not benign Rolandic epilepsy. And it is not uncommon. There's many times, at least a few times, I have had children who go for a play date and they sleep over, and then have the seizures diagnosed. Maybe that's the first time the child had been sleeping with another friend there, and then they recognize seizures. So these seizures may be more frequent than what we think. As I mentioned, 70% of the seizures are nocturnal. They are usually short-lasting seizures. They usually don't last longer. The EEG is typically diagnostic in these children. And the EEG, what we call a centrotemporal sharp waves. If you go back to this, you can see this is the temporal lobe here. This is the central region, so it's called the centrotemporal sharp waves. They are present on both sides of the brain typically, but they can be present only on one side as well. So when we see this EEG, the neurologist generally know, okay, this is the benign Rolandic epilepsy. If the story is fitting for that's why we make the diagnosis. A healthy child, singular multiple seizures, focal or generalized, and an EEG that shows benign Rolandic features. The EEG's yield is much higher when the child sleeps, so just an awake EEG may not be very informative. If the awake EEG is not useful, it's not yielding, one may have to repeat another EEG with adequate sleep. Moving on to the second most common benign focal epilepsy of childhood is called the Panetta-Polo syndrome. It is a neurologist, an pediatric neurologist in UK who described this syndrome in large series. Once again, 90% of the time the seizures happen at night time. The children who are relatively younger, actually, between 4 and 5 years is the peak incidence. The benign Rolandic is slightly older towards the end of the first decade. And one unique feature about these seizures are they are frequently long. As you can see, 44% of them are more than 30 minutes. But they are usually not the whole body shaking, generalized tonic-clonic seizures. The typical symptoms are eye deviation to one side, repeated retching and vomiting. They may look pale, and sometimes they can even have an ictal syncope, unresponsiveness. So there's a lot of autonomic features in these seizures. So a child who is confused with repeated vomiting out of sleep, this may be the diagnosis. These children, they are frequently misdiagnosed because they may be diagnosed because of the recurrent vomiting with the GI symptomatology. And because of the prolonged seizures, they may be diagnosed with the encephalitis at the initial stage. But usually, after a few hours, the diagnosis is obvious. The child is back to their usual self, not doing any problems. If you do an EEG, the usual abnormality you would see is occipital spikes. As it used to be called a benign focal epilepsy with occipital spikes. Now it's called a Ponetopoulou syndrome because you could have the same set of symptomatology with spikes or epileptiform discharges in other distribution like centrotemporal or even frontal distribution. But the most frequent location for interictal epileptic discharges is occipital region. Now moving on to this epileptic encephalopathy, these are the catastrophic epileptic syndrome. Again, there is some age-dependent categories available. And there are children who start very severe epilepsy before 3 months of age. The classical syndromes are called Ohtahara syndrome or early myoclonic epileptic encephalopathy. And the most common thing that's tested in the boards is the West syndrome that usually occurs. The peak age is before 15 months, but you can have spasms even at a slightly older age. And the Lennox-Gastaut syndrome, usually children sometimes may start with one category. As they get older, they may have different set of symptoms. They may qualify for a different syndrome. As they get further older, they may go into another syndrome. So syndrome is just a constellation of symptoms and signs with some specific EEG features. As you know, a syndrome, by definition, is a set of symptoms and signs for which there is more than one cause. So it is not based on etiology. One can have a Lennox-Gastaut syndrome or a West syndrome due to perinatal brain injury or an acquired brain injury or a malformation of the brain. So it's not etiology specific. The common features are frequent seizures, poor response to medications, associated developmental problems, intellectual disability are the most frequent associated problems. Let's make sure that this video works. Okay, good. So this is a video of a 9-month-old infant with jerks. As you can see, the child is relatively developmentally good, able to sit without support. You start seeing these quick jerks, and with the forward bending, if you look at the arms, there is some slight abduction of the shoulders. And as time proceeds, it becomes more and more intense. And this typically occurs during sleep-wake transition. Child wakes up in the morning, has a cluster of these episodes, this is called epileptic spasms. And this may go on for several minutes. Some children 5 to 10 minutes, sometimes even 15 to 20 minutes, what we call a cluster of epileptic spasms. So when we see this, this is a medical emergency. You should try to treat as much as soon as possible because there is a significant drop in IQ points if there is a delay in treatment within 2 weeks after the onset of spasms. When you do the EEG, this is what we see during the EEG, a huge burst of slow waves. And this child is called JCU 1.0 because this child had a lot of spasms and had to undergo epilepsy surgery to stop the spasms. And after stopping the spasms, the child was totally different. Developmentally, he was more babbling and was gaining the milestones pretty quickly, more engaging, interactive. So the family called us JC 2.0 on follow-up. And both the parents are software engineers from California. So they didn't realize that there is a 1.0, 2.0 until they saw the second stage after the surgery. So the EEG pattern, there are a couple of EEG patterns or 3 EEG patterns that may be tested in the boards. One is the hips arrhythmia pattern, that's this. I don't think they will show the EEG for you to recognize, but EEG is easy to recognize. EEG looks chaotic. One of our neurologists says if you put it upside down, you won't see a difference. That's what hypsarrhythmia is. So basically, high amplitude spikes and slow waves. And so this is a feature of an EEG feature of epileptic spasms. So the presence of epileptic spasms with a hypsarrhythmia and EEG and a developmental delay, which is usually cognitive developmental delay, this is a triad of a West syndrome. As I mentioned earlier, all these syndromes have heterogeneous etiologies. Some of them are idiopathic. You may not find an etiology. Many of them are genetic. We have specific genetic panels available for epileptic encephalopathies. And structural causes, including hypoxic ischemic encephalopathy, tuberous sclerosis, malformations. Down syndrome is another syndrome that is frequently linked to infantile spasms. The treatment of infantile spasms, early aggressive treatment, as I mentioned, a delay of more than 2 weeks has been associated with a significant decline in IQ points. And the two common treatments that is used in epileptic spasms is steroids, often with ACTH. And second is vigabatrin. This is one of the GABAergic drug. It is specifically used in epileptic spasms. So your common anti-epileptic medications are not very effective in epileptic spasms. So there are two unique medications. And other medications that may be used if these don't work as clonazepam, sodium valproate, topiramate, and zonisamide. Let's move on to the next question. Britt is an 8-year-old girl with episodes of staring for the past 6 months. She has sudden episodes of zoning out and arrest of activity. She may stop in mid-sentences, may appear flat, as a face look flat, lasts for 5 to 10 seconds, resumes activity soon after, happens 5 to 10 times a day, and it is not infrequent to see 50 to 100 times or 1,000 times a day in some patients. A neurological exam is normal, EEG results are pending. The most appropriate treatment for this patient is A, ethosuximide, B, carbamazepine, C, phenobarbital, D, vigabatrin, and E, phenytoin. So the treatment depends on the diagnosis. And the single most important thing that determines the treatment of medication treatment is the diagnosis. I think most of you got the diagnosis right. The diagnosis is absence seizures, absence epilepsy. And the drug of choice among this category, what we have is ethosuximide is the best drug that's available. Sodium valproate would be another equally good drug. So let me show you 2 videos. Hopefully it will play. Okay. Okay, I think there is some error in the video. Let's do this video here. So are you able to see a child here? The audio is not working here. What the dad is doing there, or the technician, whoever is doing there, is, I'm going to play it one more time, holding a pinwheel for hyperventilation, blowing. And you can see there's a body movement there, deep breathing going on there, and then it stops here. And this is when the child stops responding. As you can see on the EEG, you see what we call as 3 Hz spike wave complexes. This is a hyperventilation induced absence seizure in this patient. And sometimes you can have seizures in which patients are staring and becoming unresponsive due to a focal epilepsy, what we call the complex partial seizures. So staring unresponsiveness, there is 2 categories of seizures that can happen. One is the absence seizure, where your treatment is ethosuximide. The other one is you can have a complex partial seizure due to a focal epilepsy. So this is one of the patients, the video that didn't work is the patient was staring unresponsive. He was tested several times. He wasn't doing anything. He did not, and then he snapped out of it completely. His EEG showed a left temporal seizures due to a focal epilepsy. And the second video they showed is that during hyperventilation is what we call the absence seizures, where the EEG shows generalized 3 Hz spike wave complexes. So how do we differentiate an absence seizures from a complex partial seizures? This is very important it's often tested in the boards. The absence seizure, the duration of individual seizures are very short. They're usually 5 to 10 seconds or even shorter. Occasionally you can have absence status, but the typical patient is shorter. And complex partial seizures, the seizures are usually longer, 45 seconds to average of around 2 to 3 minutes would be the average. And the absence seizures, they may occur multiple times per day, just like in the story I showed in the question. And they often have 5 to 10, 50, 100 per day. And the complex partial seizures are relatively less frequent. They may be a few per month. And there is very minimal other movements with absence seizures, but in complex partial seizures, they may have significant orofacial chewing or fidgeting with the hands, and picking movements, rubbing movements with the hands may happen. And hyperventilation is frequently a trigger with absence seizures, which is usually not a common trigger with complex partial seizures. And in absence seizures, the postnatal confusion is rare. They kind of quickly snap out of the seizures. And postnatal confusion is common in complex partial seizures. And the EEG is probably the most important thing. The EEG in absence seizure is usually very diagnostic. And untreated absence seizures do a EEG with hyperventilation. More than 90% of the times it's positive for 3 Hz spike wave complexes. And in complex partial seizures, you will see focal spikes. In the absence epilepsy, in the classical absences that we described, brief episodes of staring several times a day, and they may be misdiagnosed as poor attention. They may not be performing well at school because of frequent seizures. And 3 Hz spike wave complex is the typical finding. And there are several categories of absence epilepsies. These typical categories: the childhood absence epilepsy with a peak age between 6 to 7 years, with a broad age range. And in them, absence seizures may be the only seizure type. About 10% of them may have other seizures, including grand mal seizures. And about 70% of this childhood absence epilepsy, they enter into remission during adolescence. So the chances for outgrowing is pretty good with childhood absence epilepsies. And the treatment of choice usually is ethosuximide. The commonest side effect that limits this treatment choice is GI upset. They may have nausea, vomiting, and abdominal pain. That is the most frequent side effect of the ethosuximide. Valproate is a good drug, equally good drug in terms of efficacy, but because of the side effect profile, most of the families do not prefer valproate as a first drug. Lamotrigine is the third best option. And we have juvenile absence epilepsy. The childhood is the younger age group. Juvenile absence, the peak age between 10 to 12 years. Again, they have normal development, normal exam. Otherwise, if somebody does an MRI scan, it will be normal. And they have more chances to have other seizure types. And the chances for outgrowing are relatively less compared to the childhood absence epilepsy. They persist longer, but they usually respond to treatment. And if the other seizure types are present in these patients, often valproate or lamotrigine may be better choices. So if the child has got only absence seizures, ethosuximide would be an ideal drug. But if the child has got other seizure types, sodium valproate would be a better drug. And the third category is the juvenile myoclonic epilepsy, which the peak age is between around 15 years of age range between 12 to 18 years. The juvenile myoclonic epilepsy, there are 3 seizure types. And the 2 are very important, mandatory for the diagnosis of JME. It's called the juvenile myoclonic epilepsy. The generalized tonic-clonic seizures and myoclonic seizures has to be there for the diagnosis of JME. But about 40% of them may have absence seizures. Sometimes the child may start as an absence seizure at a younger age, may develop myoclonic seizures and generalized tonic-clonic seizures at a later age. Again, these syndromes may evolve from one syndrome to other syndromes, just like the other catastrophic epileptic syndromes. Family history may be present in about 1/3 of the patients, and the treatment, the drug of choice for juvenile myoclonic epilepsy would be valproate, but because of the age group it occurs, and in women there is a lot of side effects with valproate, include weight gain, hair loss, polycystic ovary syndromes, and there are some teratogenic risks to babies. So valproate is usually not a preferred drug in young women. Levetiracetam is often used. If there is absence seizures, lamotrigine would be a better drug. If the absence seizures are dominant symptom, you may have to add ethosuximide too. So one of the things that's tested in the boards is to identify the etiology or the type of epilepsy syndrome. So you have here, I have created a match the diagnosis list here. On the left-hand side, you have the clinical condition, and the right-hand side, you have the various syndromes. Let's talk about the options here. Hypoxic ischemic encephalopathy, juvenile myoclonic epilepsy, febrile seizures, infantile spasms, benign atlantic epilepsy. I think we covered most of it. A 17-year-old with arm-body jerks in the morning. The juvenile myoclonic epilepsy, the myoclonic jerks typically occur early in the morning. Sleep deprivation often brings on these myoclonic jerks, and comes to the doctor after one generalized tonic-clonic seizures after the prom night. Sleep deprivation is often a trigger. So the answer is juvenile myoclonic epilepsy here. A 9-month-old with episodes of head drops, jerks during sleep-wake transition. The examination shows 3 hypopigmented macules. It's probably a neurocutaneous syndrome. The head drops, just like the video I showed, is epileptic spasms or the infantile spasms. An 8-year-old, otherwise healthy, normal child, 3 episodes of right arm and face shaking and jerking, all in sleep, is a typical story for a benign atlantic epilepsy. So if you look at the story, other existing problems, as well as the type of seizures, age group, all these things will help you to make a syndromic diagnosis. A 2-day-old newborn with several seizures, the most common etiology for seizures in newborn is perinatal brain injury due to hypoxic ischemic encephalopathy. And a 9-month-old healthy infant with fever due to otitis media and a single generalized seizures, the typical scenario for a febrile seizures. Okay, that's the answers there. Neurocutaneous syndrome, when I came a little earlier, I saw that some of these things are already covered in the neurocutaneous talk, the previous talk. This is the typical features of tuberous sclerosis. You have Astley macules, the baby we talked about, the epileptic spasms and hypopigmented macules was due to tuberous sclerosis. There is forehead plaque, subungual fibromas, shagreen patches, which is kind of raised orange skin-like patches, and adenoma sebaceum, which occurs usually around puberty time, rather flares up during puberty. So tuberous sclerosis is one of the classical neurocutaneous syndromes associated with seizures. They can present with infantile spasms and in infancy. And autism is frequently associated, and the brain MRI scan shows tubers and subependymal nodules. Those are the typical findings. The other feature is Sturge-Weber syndrome, where you have a port vein stain on the upper half of the face affecting the upper eyelid and the forehead, and usually accompanied by intracranial leptomeningeal angiomatosis, as we can see in the MRI scan here. Again, Sturge-Weber syndrome, headaches are common in older children. Seizures, sometimes they can have recurrent status epilepticus as a common finding. Glaucoma is in the affected eye is also a finding. In terms of testing for epilepsy, EEG in the boards, it's often the questions are phrased in such a way that EEG is not useful. The neurologists, if you ask neurologists and epileptologists, they'll think the EEG is the most useful, but the truth is somewhere in between. It depends upon the syndrome we diagnose. Many times, benign atlantic epilepsy and absence epilepsy, EEG is the tool to go by. Infantile spasms, if you're looking for hips arrhythmia, EEG is very important. And EEG abnormalities does not necessarily reflect the severity of epilepsy. As I mentioned, the benign focal epilepsy of childhood, the seizures may be infrequent, child will outgrow, the EEG may look very abnormal. And negative EEG with the frequent seizures in a child, one should suspect non-epileptic events as well. So one should be wary of that. Again, EEG in most instances is not required for febrile seizures. MRI scan is more preferred than the CT scan. As you know, CT scan has got radiation issues. The MRI scan, the problem is in young children one may have to use anesthesia. And there are 3 situations, and imaging is a low priority. One is the absence seizures, and this benign focal epilepsy is in classical scenario. We won't do imaging. And some idiopathic generalized epilepsies, imaging is not a priority in these kind of situations. Serum biochemistry is probably useful in acute situations, patients in the ICU, newborns, Many times these labs are done before anti-epileptic medication initiation for monitoring purposes. And in young infants with epileptic encephalopathy, this one may have to do inborn errors of metabolism workup. So we'll go over the etiology, testing for the etiology. This is kind of the same set of scenario, but we have different tests available here. I believe I don't have I think probably answers are matched here for your convenience. 3-day-old newborn with a GBS positive mother, seizures. The most important testing is required. It is the lumbar puncture there. Again, you don't do a lumbar puncture otherwise in most patients with epilepsy. And a 9-month-old with episodes of head drop, jerks during sleep-wake transition, infantile spasms. The exam shows hypopigmented macules. You would do an EEG and the MRI scan, because EEG to look for hypsarrhythmia, confirm epileptic spasms, and MRI scan to find out the etiology. In somebody with hypopigmented macules, you're looking for tuberous sclerosis. An 8-year-old, otherwise normal child, 3 episodes of right arm jerking. We talked about the benign Rolandic epilepsy. The most important test, the EEG. And this 3-month-old with status epilepticus and no fever, a serum sodium of 112. I'm sure the pediatricians will definitely review the feeding history. Hyponatremia is often tested in the boards. Abnormal feeding practices may be causing this seizures. So when you see seizures in the boards, don't always think it's the epilepsy. It may be an acute symptomatic seizures due to medical conditions, which a pediatrician will be more familiar than a neurologist. A 9-month-old with a healthy infant with fever, otitis media, it's a febrile seizure scenario, you generally don't do any tests. So the tests also depend upon what is your primary diagnosis. And so the age, the type of seizures, and the accompanying findings may give you a clue to the diagnosis, a comprehensive diagnosis. In terms of treatment approach, do we have 2 more minutes, Dr. Isabella? We're good? Okay. I think this is one of my favorite questions. Let me see here. So Johnny is a 6-year-old boy present with 3 episodes of stereotyped events over 2 months. Zoning out, sudden arrest of activity, some chewing and lip smacking and picking behaviors with either hands, lasts for around 1 to 2 minutes. Post-ictally, he is asleep for 1 to 2 hours. Neurological exam, EEG, MRI are normal. The most appropriate treatment for this patient. So the type of seizure is probably the most important deciding factor. As you can see, zoning out, lasting 1 to 2 minutes, post-ictal confusion. The options are ethosuximide, B, carbamazepine, C, phenobarbital, D, vigabatrin, and E, phenytoin. What would be the most appropriate medication for somebody with what looks like a complex partial seizure? Ethosuximide would be for a childhood absence, right? And the most appropriate medication would be carbamazepine. Most of you got it right. And again, ethosuximide, if this had been an absence seizure, that would be the right answer. Phenobarbital is a broad spectrum anti-epileptic, but carbamazepine has got a better side effect profile, is a more narrow spectrum for partial seizures. Vigabatrin, we use it exclusively in pediatric, always only used for epileptic spasms. We do not use vigabatrin for any other indication in pediatric. Would be unusual. Phenytoin, again, is a broad spectrum. It could be used for focal seizures, but a preferred drug in terms of side effect profile-wise would be carbamazepine. In selected cases, we won't start treatment, like benign Rolandic epilepsy. The child comes with 2 seizures. The EEG looks very abnormal. We know that there may be recurrence risk may be high, since these children tend to outgrow their seizures with time, and the seizures are usually short-lasting in sleep. Many times we don't start them on daily anti-epileptic medications. One should always weigh the risk of anti-epileptic drug-related side effects, and one should monitor for cognitive side effects. And one may have to substitute medicines depending upon the side effects. And one should always look for metabolic epilepsies as well. In young children with refractory epilepsies, pyridoxine-dependent seizures, folinic acid-dependent seizures could be the etiology. So this is a cartoon that highlights the different types of seizures and the medications. I would not go over this. Once again, absence seizures, these are the primary medications. Spasms, these are the primary medications. And there is a lot of options available for other seizure types. Okay, let's move on here. So I think in the handout, you also have the common side effects related to the caused by the anti-epileptic drugs. And the ones they highlighted are often tested in the boards: hyponatremia with carbamazepine, Stevens-Johnson syndrome with many of the first-generation anti-epileptic drugs. Again, felbamate can cause liver failure. Lamotrigine, the most important side effect would be Stevens-Johnson syndrome. And you have a whole lot of other side effects that is listed here. And in general pediatrics, as I mentioned, the acute symptomatic seizures could be related to hyponatremia or hypocalcemia. Always look for, in the boards, look for clues for metabolic etiologies. If there is a mom has hypoparathyroidism, or a child, a young infant, frequent seizures, otherwise healthy looking, all those things may indicate metabolic seizures. And these are some of the other causes for metabolic causes for seizures in children. I think I should move on to the last slide here. So this is highlighting some seizure precautions. This is probably common precautions one should advise all the families. So we went over the definition for epilepsy, and then what is not epilepsy, which is febrile seizures and provoked seizures. And single seizures, what should we do? One should be testing, may not be treating always. And the common epilepsy syndromes, which includes the most common ones in the pediatric practice, the absence seizures and the benign Rolandic epilepsies. And the treatment approach is primarily dependent on the seizure type and the side effect profile. Thank you very much. Good luck with your boards.